Next, we're going to talk about some airway adjuncts. And on the table here in front of me, you're going to see some nasopharyngeal airways and some oropharyngeal airways and the different sizes of each. We actually have a size 4 OPA or oropharyngeal airway all the way up to a size 10. And in terms of the nasopharyngeal airways, we have a 5, a 6, a 7, and an 8. The nasopharyngeal airways come individually packaged. And on the packaging there, you will see it's listed as a nasopharyngeal airway, and it will give you the size. We'll demonstrate how to size your patient for the appropriate size nasopharyngeal airway as well as the oropharyngeal airway. We'll discuss indications, contraindications, and some adverse effects with inserting OPAs and MPAs. Next, what we're going to do is we're going to size this child for an appropriately sized oropharyngeal airway. So one of the things that you can do is you can look on the front of the flange and it will tell you the size of the oropharyngeal airway. The other thing is you can come over to your patient and use from the side of the lip to the angle of the jaw here, and you should be able to have the tip of the end of the oropharyngeal airway at the side of the jaw or the angle of the jaw, and then the flange will be at the side of the lips there. So that looks like an appropriately sized oropharyngeal airway for this patient. Oropharyngeal airways and nasopharyngeal airways are designed to prevent the tongue from falling back and blocking the glottic opening, causing an obstruction for breathing. So they're very effective in children and adults who don't have effective breathing, maybe somewhat semi-conscious, and do not have an active cough or gag. So those are your best candidates for these types of airway adjuncts. They're definitely contraindicated in patients with an active cough or gag reflex, as they will cough and gag them out, potentially causing your patient to vomit. So be aware of that. So in order to insert the OPA into this patient, insert anti-anatomically along the hard palate to the edge of the soft palate. Once you reach the soft palate, give it a 180-degree turn, and it will seat in nicely, and then hook the back of the tongue to prevent it from moving forward. With that curvature of the OPA, the hopes is it's going to hook onto the tongue and keep that tongue forward so it doesn't fall back and cause an obstruction for this patient. As their cough and gag reflexes begin to return, you will see that patients will start to cough, gag, and probably spit it out. If they're unable to do so, it's very important that the nurse at the bedside is able to react quickly to remove that in order to prevent vomiting and aspiration. We have an infant patient here that we are going to size up and insert an oropharyngeal airway into. So same thing with your pediatric patient. You want to use your flange at the edge of the mouth and the tip of the oropharyngeal airway to the angle of the jaw. So just like so, you kind of get an idea that that is a good size for your patient. And then the technique for insertion is just a little bit different than it is with your pediatric child, where you would normally go in anti-anatomically and then turn anatomically. You are going to insert this anatomically with your infants. After you sized up your oropharyngeal airway, babies that have large tongues could potentially, the tongue could be potentially in the way. So you may need an assistant to help with pulling the tongue out just a little bit so that you can insert the oral airway anatomically. So you can use gauze for your assistant to kind of grab a hold of the tongue and just hold that forward. Or with a piece of gauze and McGill's, you can just have the McGill forceps in the mouth to just kind of hold the tongue forward if you have difficulty passing the oropharyngeal airway in. So remember, with the infants, it's going to be an anatomical insertion, just like so. So in the mouth, and just follow the anatomical curvature of the tongue and place it in just like so. So now we're going to demonstrate the use of a nasopharyngeal airway and its insertion technique. So with this child here, he's a smaller pediatric child. So we're going to start with a 5 millimeter nasopharyngeal airway that you can see there on the packaging. Okay, so we're just going to open our packaging up and remove our nasopharyngeal airway. So for sizing, a little different than the OPA, we are going to use the tip of the nair here, as well as the ear tragus right there. So the flange will rest against the nair, and the tip of the nasopharyngeal airway will go to the ear tragus. Okay, so we'll just line that up there. So there it is at the nair, and then you'll see the tip is just at or just past the tragus there. So maybe a bit long for this patient, but definitely an appropriate size. So before we insert it into the patient, we need to then lubricate it. So typically we will use a water-based lubricating jelly, such as Muco. So what I would normally do is just put a little bit of the lubricant inside the package here, and then grab my oral airway and lube that up nicely. When you go back to the patient to insert it, you want to make sure that the bevel on the tip is going to go along the nasal septum. All right, you insert it in the nair just along the septum. You give it a bit of a twist as you go in. And then you may meet a bit of resistance as it gets to the back of the throat and the tongue. But that's a very easy insertion technique. It actually is quite comfortable for the patients, actually very much more preferred than the oropharyngeal airway. Because it doesn't stimulate the cough and gag like the oropharyngeal airway. One thing to do keep in mind though is it can invoke laryngeal spasms. So that's one thing where you may need to keep an eye out for those coughing fits associated with laryngeal spasm. The other thing that you need to be worried about is checking your INR and PTT if there's any coagulopathy. If there's any recent trauma to the nares or head trauma, such as a basal skull fracture, you do not want to insert a nasopharyngeal airway for those types of patients. Okay, as you can see, well tolerated. It allows direct passage from the nares to the back of the throat. You can even facilitate open suctioning with a suction catheter down the nasal trumpet or nasopharyngeal airway as well. So we're going to talk about positive pressure ventilation or manual ventilation now. So this is our ability to provide temporary airway support using the Bag-Valve mask. We have different types of bags. We have our flow-inflating bag and our self-inflating bag, and then we have different sizes of anesthesia masks here that are laid out on the table in front of me here. So the key to providing positive pressure ventilation is establishing an airway, being able to breathe for an infant or a child who are not breathing appropriately on their own. Positioning is very important. Using things like the nasopharyngeal airway or the OPA to assist you with providing positive pressure ventilation via BVM, or as well as using a partner for doing a two-person seal technique, which we will demonstrate for you today. Okay, so there's the one-handed or the two-handed technique. So the first bag that I'm going to show you today is the flow-inflating bag. Now the flow-inflating bag requires a little bit more skill and experience than the self-inflating bag. But in the packaging, it comes with a gas reservoir here, oxygen tubing, and a manometer that will give you an idea of what your pressures that you're bagging your patient with. So you can set your PEEP level on this by using this blue dial here, and then depending on how hard and fast you squeeze the bag, it will generate a pressure in order to deliver the breath that way. Okay, so that is your flow inflating bag. Again, with your flow inflating bag, you need a gas source in order to use this. If you don't have a gas source, then this is not going to be of any assistance to you or your patient. After you've taken your flow inflating bag out of its package, you're going to take your one end that's not attached to your bag and attach it to your flow meter. Okay, and then we're going to set our flow to 10 liters a minute. Again, making sure that your float is centered right at the 10. So then we'll come back to our bag, and now we're going to set it up for patient use. So what we're going to need to do is occlude it on the open end here at the patient connection. Allow the reservoir bag to fill up, and then we'll be able to start to see a PEEP level. If we're not seeing anything, we can adjust the blue dial here on the side in order to adjust our PEEP level. Okay, I'm going to set for 5 here, just by adjusting that level. Okay, and then my next thing to do the test is just give the bag a squeeze. So the green zone is the safe pressure zone. Okay, if you need to get a little bit more pressure, that's in the yellow. You just squeeze a little bit harder. And if you have to go high in the red zone, you got to really squeeze the bag in order to do that. Okay, so that's your test to ensure that your flow inflating bag is working correctly. If you had to bag your patient using the flow inflating bag, it's important to have the properly sized mask for your patient. I have 3 different size masks here that I can choose from, just laid out here on the bed. I have a size 2, a size 3, and a size 4. So if I was to go with the size 2 first, it will show you that the mask is actually too small for the patient. It's actually got holes here at the corner of the mouth. It's not fitting nicely over the bridge of the nose, and the lip is kind of caught underneath on the bottom there. You can barely see that, but that's a good indication that this mask is too small for this patient. Okay, if I pick a next mask and I pick a size 4, the size 4 is likely going to be too large for this patient. How do I know it's too large? It's covering the patient's eyes. You don't want that. You want it to fit nicely over the bridge, the tip over the bridge of the nose, and then just around the chin, sealing the mouth and the nares under the mask. So this mask here is too big for this patient. So a size 3 seems to be an appropriate size mask for this patient. As you can see, not in the patient's eyes, covers the bridge of the nose here, and just sits nicely under the bottom lip above the chin. There's no gaps on either side of the lips, and I have once I bag, I'll know if I have a good seal. Once I get pressures showing on my manometer, and whether or not, once I actually start to manually ventilate, I will look for chest rise. Our patient is in respiratory distress, not effectively breathing, and we want to support and assist his respirations. So the biggest thing with bag mask ventilation to make yourself successful, proper patient positioning, okay? So with this patient here, and we're on the stretcher, we're going to drop the head of the bed so that it's flat. Okay, we have our bag nearby. We can actually provide some blow-by oxygen while we're doing this. And then we're going to reposition, make sure that the patient is midline and in line. Okay, and then we want to make sure that we have something under the shoulders to sort of open the airway up for this patient here. So it could be a roll, it could be using the pillow, or even taking the pillow away to properly position your patient. And then as the person who is going to be providing the positive pressure ventilation via the bag and mask, you're going to want to come around to the head of the bed. You are going to then place the mask on the patient's face and provide a seal. By doing so, I'm currently using the one-person EC technique. So these 3 fingers here are making the E shape, and these 2 fingers here are making the C shape. So the C shape is on the mask, holding the mask on the patient. The E fingers are actually grabbing the bottom of the jaw, lifting the jaw up to open the airway. And now I have the bag filled. I have a PEEP of 5. So once we determine we got a good seal, we're going to start manual respirations, and you should be able to see the chest rise with each breath. Right now, I am just maintaining a mask seal with the patient using the EC technique. I'm actually not manually ventilating the patient, so this is where you're able to provide a little bit of CPAP to the patient if they're spontaneously breathing, just by holding the seal on the patient's face like that with the mask. Okay, and if you had a spontaneously breathing patient, you will see the bag title as the patient breathes. And that is the applying CPAP. So next we're going to demonstrate how to provide positive pressure ventilation with a self-inflating bag. So this is a self-inflating bag right out of the package. So it comes together already with your oxygen tubing here, your valve on the end, and then another valve over here at your patient end. And we have a reservoir bag that will attach to the end here. And then we also have an inspiratory filter that comes in the package that will attach to your self-inflating bag here. So the important thing to remember about the self-inflating bag is it needs to be tested just like the flow-inflating bag. Okay, so first test that you want to do is just occlude the end and squeeze the bag and hear a pressure pop off. Okay. So that will pop off when the pressure level gets to 40 centimeters of water, and you'll hear that there. The next one is to lock the pressure or close the pressure pop off. So the pressure pop off is now closed, and all you want to do is squeeze the bag to see that it's maintaining pressure, and it is. Okay, so that's your third test. You're going to open that, make sure your pop off pops off again, and then your third test is just to squeeze the bag and make sure it reinflates. So those are the 3 steps that you want to perform as you're testing your self-inflating bag. We're now going to use the self-inflating bag on our patient. We are going to take our end of our oxygen tubing and attach that to the flow meter on the wall. We are going to turn our flow up to 10 liters per minute. You're going to take your mask and attach it to your bag, just like so. Make sure your connections are nice and tight so they don't come apart as you're providing ventilation for your patient. You also have the ability on this port right here to attach a PEEP valve if you needed one right there, okay, to set a PEEP level higher than 5. So our patient is no longer breathing, okay. So just like in the previous video, we want to ensure proper positioning of our patient. We are going to remove the pillow. Okay. And then this time here, we are going to use a roll under the shoulders to open the airway up just a little bit more. The thing with children is their back of their head is quite large and sometimes will cause a little bit of hyperflexion when they're laying on a bed or a pillow. So what we need to do is just extend the neck a little bit more just to open the airway. We don't want to hyperextend it. And what I mean by that is causing your patient to look like that. You want to be just slightly extended in a nice midline position. Okay. So you're going to come over to your patient, ideally from the head of the bed. You're going to use the same EC technique to get a seal. So a C on the mask and a E on the patient's jaw. Bring the jaw up to open the airway a little bit more, and then provide some mechanical or positive pressure ventilation. And you can see chest rise with that. Okay. So we're now going to demonstrate the two-handed seal technique, which you will require an assistant for. So your assistant is going to take both their hands, create that EC seal on either side of the patient's mouth and mask, and then you as the person holding the bag are going to provide positive pressure ventilation. and then you're going to hopefully look for chest rise. So these are, this is an important technique to consider when the one-person technique is failing to adequately ventilate your patient. So we just finished bagging this patient with the two-handed technique, and we're still having difficulty getting air into the chest and moving the chest. So what we can then do now is bring in our OPA or our MPA to help facilitate positive pressure ventilation because we were unsuccessful with the one-handed or the two-handed technique. Remember to size your OPA appropriately by flange at the tip of the outside part of the lips and the tip at the angle of the jaw. Bigger child, we're going to insert anti-anatomically along the hard palate, opening the mouth just a little bit till you get to the soft palate, twisting to seat in there, and then resume positive pressure ventilation. So you can try the one-handed technique because it could be the tongue that is potentially causing the issue. If not, then you're going to move on to the two-handed technique with an assistant to provide positive pressure ventilation, looking for chest rise and an improvement in vitals and oxygen saturations. Okay. The other option would be to insert the nasopharyngeal airway, which we had sized previously. Again, lube it up to size again, side of the nair to the tragus of the ear. So you're going to take the bevel here along the nasal septum. Just follow the wall of the septum to allow for insertion of the nasopharyngeal airway. You may feel a little bit of resistance as it hits the back of the tongue, and then you're inserted that way. One of the other things to keep in mind with positive pressure ventilation is the insertion of an OG or an NG to help decompress air off of the stomach, depending on how aggressively they needed positive pressure ventilation. And again, go back to your one-person technique. And if you're unsuccessful at delivering positive pressure ventilation, move on to your two-person technique.